Hello and welcome to the Year 1 Module 2 training for primary care. My name is Sarah Moore and my pronouns are she, hers. I'm excited to present this information to you over the next couple of hours while we discuss organizational support for suicidal risk and patient self-management. We appreciate all that you do daily to prevent suicide at the practices that you work at. This is what we will cover today. I will start by covering MyMind recommendations for suicide risk screening and assessment, and highlight the importance of providing lethal means counseling in both primary care and behavioral health. Next, we will discuss the importance of involving loved ones in the care of patients who are at risk for suicide, as well as cover other patient self-management strategies, including providing community resources for support, collaborative safety planning, and providing caring cards or follow-ups after an appointment. Last, I will introduce the suicide prevention care pathway and discuss strengthening care pathways and how coordinating between primary care and behavioral health can decrease suicide risk for our mutual patients. I'll wrap up today's meeting by giving you some reminders, including key takeaways for the training today, as well as things to keep in mind coming up. As always, make sure you're taking care of yourself physically and emotionally while you review this information, and let us know of any ways that we can support you in the trainings and outside of the trainings going forward. Thank you for being here today. Just a reminder here, support for MyMind is provided by Blue Cross Blue Shield as part of the BCBSM Value Partnerships program. Although Blue Cross and MyMind work collaboratively, the opinions, beliefs, and viewpoints expressed in this training do not necessarily reflect the opinions, beliefs, and viewpoints of Blue Cross or any of its employees. I'll start by discussing how screening patients for suicide risk in primary care can help identify patients in need of further assessment and intervention. At MyMind, we promote asking every patient about suicide risk at every encounter. Some patients may openly discuss suicidal thoughts. Others may indirectly indicate risk of suicide or self-harm, while other patients may live in silence with the pain of feeling that it would be easier to not be here or that others would be better off without them. Dr. Frank, a MyMind co-director, would say that we must keep in mind the people who are silently at risk or who do not know that they are at risk. These are the individuals that need every opportunity possible to get the help that they need. We recognize this can feel like another ask for busy providers who are already addressing so many things in a short amount of time. So we are hoping that the entire clinic can come together to support screening efforts. And most of you are already familiar or aware of questionnaires that make screening for suicide risk easier. Others may be feeling like there is not enough time to ask patients one more question. So today we are going to discuss how you can automate the screening process to be as streamlined as possible using the PHQ-9, as well as discuss some other possible questions to use with patients that can support identifying suicide risk. Henry Ford Zero Suicide Guidelines recommend using the PHQ-9 at every clinical visit. The ninth question of the PHQ-9 specifically screens for thoughts that the patient would be better off dead or of hurting themselves within the past 2 weeks. Although the screening may not need to be done at weekly intervals for patients who are coming in more frequently, repetition can be helpful for patients to get used to the process of completing the questionnaire and ensure that patients are not being missed. It is critical that both primary care and behavioral health providers screen for suicide risk, as we know that if we do not screen in primary care, many patients may fall through the cracks. When administering the PHQ-9, it is important that the provider reviews the score at the beginning of the appointment. The sooner the provider knows the answer, the sooner they can plan for what next steps or which care pathway to use. While we recommend screening patients with the full PHQ-9, we do understand that this may be a difficult task for both for busy primary care clinics. For that reason, it is also acceptable to start with the PHQ-2 plus item or question 9 when screening for suicide. I did highlight the questions that we suggest using if unable to use the full PHQ-9. So questions 1, 2, and 9 are highlighted here on the screen. And you'll hear us say PHQ-2 plus item 9 or plus question 9 throughout the trainings and throughout my mind discussions and in the training today. There are some other questions in the PHQ-9 screener that also relate to suicide risk, such as questions that ask about difficulty with sleep or feeling bad about yourself. For this reason, we promote completing the full PHQ-9 questionnaire with patients when possible. At my mind, we think of the PHQ-9 as our behavioral health vital sign. It is important to recognize the difference between screening for depression and for suicidality. In the upcoming slides, we will discuss further the importance of screening for suicide risk among all patients, especially because we know that a primary care doctor is often the last provider that a patient sees prior to a suicide attempt or death. Now, when considering doing the PHQ-9, there can be some hesitancy due to worrying that this can potentially make for more work for providers, as well as concern about not having the staffing to address the scores in a timely manner, especially if those are being completed via the EMR, or electronic medical record. So to calm some of those fears, I want to mention here that per the research, only about 2.9% of primary care patients scored a 2 or 3 on question 9 of the PHQ-9. So 2.9% is the average for patients that will score a 2 or 3. That means answering more than half the days or nearly every day on that question number 9. And research states that there is more of a longitudinal risk than a same-day risk here. Obviously, looking at the statistics, research does state that there is increased suicide risk for those with a positive screen, but it does not necessarily mean that we must ring the alarm the second that that score comes in. The hope is that screening processes will be streamlined and EMRs can be leveraged to put protocols in place to help providers address suicide risk. There are some safeguards that clinics can put in place when using the EMR for screening, such as sending out the questionnaire 48 hours prior to the patient's appointment, and putting some wording in the screener recommending that the patient go directly to the ER if they are in danger of killing themselves. We suggest that clinical staff contact the patient the same day if they are a new patient to the clinic and they score a 2 or 3 on question number 9. And if they're an established patient, the recommendation is for clinical staff to follow up within 48 hours or using best clinical judgment. It may be helpful to check with the legal team at your PO to ensure that they approve of the wording of the disclaimers and protocols. I know that as our primary care partners, most of you are probably familiar with the Framingham Heart Study and risk model, and possibly the research that was behind this. So to make it short and sweet, this study is related to research on screening for risk factors and stratifying risk for cardiovascular or CV disease. So this is an iconic, multi-generational and longitudinal study that found the Framingham score to be used to help physicians quantify risk and guide preventative care related to cardiovascular diseases. The study found 20 to 30% likelihood of coronary heart disease for a patient in the highest risk bucket or that has the highest risk factors. And this research really changed the way that healthcare providers screened for CV risk and the care that they provided to patients at higher risk for CV issues. It's why in routine physicals, doctors check for high blood pressure, high cholesterol, unhealthy eating patterns, smoking, etc. At MyMind, we have adopted a similar understanding of the suicide risk model using the PHQ-9 for screening and suicide prevention. Research demonstrates that the likelihood of a person having a suicide attempt or dying by suicide during the 2-year period after a positive score on the PHQ-9 item 9 is 50% more likely, again really showing that longitudinal risk over the 2-year period. MyMind is utilizing the PHQ-9 as a gold standard of care, and like the Framingham risk model, the pioneers of zero suicide in MyMind created an assessment and guidance for next steps based on research that has been done on the PHQ-9 and risk factors for suicide. Some of our participants are using other questionnaires in their practices, and we want to recognize some of those here. You may see references to these in notes from behavioral health, and it's good to be aware of screenings that behavioral health partners may be using too. We do suggest using the PHQ-9, or at minimum, the PHQ-2 plus item 9 or question 9 from the PHQ-9 if a full PHQ-9 is not feasible. Now you will also notice on this slide that we call out the Columbia Suicide Severity Rating Scale, or CSSRS. This is another screening tool that is commonly used to gauge suicide risk. Although you won't be affected by the screening performance measure in the first year of the program, in future years, participants in MyMind are scored on a performance measure related to screening, and for that we consider the PHQ-2 plus item 9, the PHQ-9, using item 9 for both of those to screen for suicide risk. For this measure, we will also consider the CSSRS using question number 1 of the CSSRS to screen for suicide risk. Okay, so moving on to the zero suicide risk assessment. Now that we have discussed how primary care and behavioral health can screen and identify those at risk for suicide, in a moment we will discuss the assessment that will be done in behavioral health. While we do not expect primary care providers to complete a comprehensive suicide risk assessment, it is important for primary care to be aware of the risk factors for suicide, especially risk factors related to high and acute risk. So we often associate depression and SUD with suicide, but I wanted to take some time to look at the research on this. This graph originated from a study that included a dataset of over 2,600 individuals from 8 healthcare systems who died by suicide between 2000 and 2013. This is compared to a control group of over 260,000 individuals who did not have a death rate related to suicide during those same years. Among patients in the case group, 51.3% had a recorded psychiatric diagnosis in the year before death. After adjustment for all listed diagnoses, or looking at the fully adjusted model, suicide risk remained highest among individuals with diagnoses of bipolar disorder, depressive disorders, and schizophrenia spectrum disorder. The risk of suicide death among those diagnosed with bipolar disorder was higher for women than in men. Statistics show that only 45% of people that die by suicide were given a mental health diagnosis within the year prior to suicide, and in this study here, only about 29% of those individuals received specialty behavioral health outpatient treatment. If you look at the graph, you will see that 9 physical health conditions, including back pain, brain injury, cancer, congestive heart failure, COPD, epilepsy, HIV and AIDS, hypertension, and sleep disorders were associated with suicide. Hypertension and back pain were the most common conditions for individuals who died by suicide, in both the control group and when adjusting for age, sex, mental health, and substance use disorder or SUD. Previous research on the U.S. veteran population has implicated chronic back pain as a strong risk for suicide. However, further research is needed to investigate whether opioid use for pain management contributes to risk. TBI had the largest increased odds after adjusting for other variables. A diagnosis of a sleep disorder also showed increased odds at 19% compared with less than 5% of the control group. Multimorbidity was also considered in this study, and it was found that having 2 or more diagnosed physical conditions was also associated with an increased risk for suicide, even after statistical adjustment for age, sex, and psychiatric conditions. Then this information tells us that if efforts are targeted mostly at our behavioral health patients, those efforts will miss the majority of the patient population that is at risk of dying by suicide. And we know that a significant change in health status can be a major stressor that often precipitates feelings of hopelessness and helplessness. So I wanted to preface this part of the presentation today with a slide to clarify what we expect from primary care and behavioral health in relation to suicide risk screening and assessment. Just a reminder here that screening is meant to identify someone who is at risk for suicide. The screening, for example, the PHQ-9, can be completed 3 ways: verbally, someone asking the patient the questions, having the patient complete the questionnaire themselves on paper, or the patient may be able to complete the suicide risk screening electronically via the EMR before their appointment. Screening is also something that support staff such as an MA or a case manager or nurse can help with. Assessment must be done with a patient in real time and further helps to quantify risk and aids in decision-making about next steps. For example, if primary care would not immediately send someone to the ER, if they answered nearly every day to that question number 9 of the PHQ-9, without asking some more questions about what's going on with the patient, getting a little bit more context and understanding of the risk, right? So once screening is completed in primary care, the primary care provider should assess for immediate danger, asking about plan and intent, as well as access to lethal means and history of and current substance use or abuse, as well as being aware of and looking for acute or high risk factors in your patients, which we will discuss during the training in just a bit. Once a patient is referred to behavioral health, the behavioral health provider should screen also for suicide risk using the PHQ-9 and assess for immediate danger, same as primary care. However, they will be completing the comprehensive zero suicide risk assessment while completing their biopsychosocial assessment. We delve into the zero suicide risk assessment here in a few, and just wanted you to keep in mind that we do not expect primary care to complete this assessment, but more so be aware of the risk factors when working with patients that might be at heightened risk. We also want primary care to be aware of what their behavioral health partners are doing and vice versa. I wanted to provide some tips and do some myth busting related to asking the suicide question. First and foremost, asking a person directly about suicide actually has the potential to lower risk. We should be careful not to focus solely on suicidal ideation as the main determinant of risk, and keep in mind other risk factors that cause a patient to be at heightened risk for suicide. It is important to recognize that at times the patient does not even realize that they are at risk until they are out of hope, feeling helpless, or feeling that ending their life is the only way to find relief. Asking questions about extreme anxiety, chronic pain, and substance abuse can help you identify patients in need of further intervention to prevent suicide. Always take all signs seriously and use screening tools that help providers identify those at heightened risk and open up the conversation. We understand that providers may have some anxiety related to asking the suicide question. So you'll see here on the screen that there are some tips and prompts to get you started when having the conversation with your patients. All of these are important, but a few that I want to highlight are: allow the person to talk openly and freely, and try to be present and be in tune with your body language and facial expressions and tone when you're having these conversations. Remember, if you're still getting comfortable asking about suicide, it's important to push through that discomfort and ask anyway. The more you practice, the more you become comfortable, and when in doubt, always ask about suicide. Here, I just wanted to mention the elephant that can be lingering in the room sometimes. So patients might come in looking very down or distraught, and even though we care and want to be supportive, it may feel like asking about suicide is opening a can of worms. I just want you to keep these things in mind in those situations. So your body language is always saying something to the patient, especially if you are uncomfortable asking the patient who is depressed or angry or anxious about suicide. So your body language can kind of tell on you here. And this uncomfortable feeling usually stems from the concern for the patient, and it really is important to address within yourself as a clinician. So doing some of that internal work. And letting the patient know that you care and want to support them can help ease both the provider and the patient's discomfort with the suicide question. Now, sometimes it can be the patient being more avoidant than the provider. So in this case, be persistent, let them know that you care and are open to listening. When asking the suicide question, it is best to ask directly about suicidal ideation. I did provide some less direct approaches to help start this conversation with a patient, but we recommend only using the less direct approaches as an opening to having a more direct conversation about suicidal thoughts. So, for example, you might say to the patient, you seem really down today. And then saying, after you talk a little bit with them about what's going on, I'm concerned about your safety. Have you been considering suicide? Here are some possible follow-up questions. After a patient acknowledges suicidal thoughts, it is imperative that both primary care and behavioral health ask about plan and intent. So the first two you see here are non-negotiable. For primary care, it is most important that you ask plan and intent questions. However, you may find it helpful to ask some additional questions to have a better understanding of a patient's risk level, so that you as the provider can feel more comfortable with the patient's plan of care. These questions can also help determine what supports can be included in patient care. You know your patients best, so depending on the patient and the context, any of the questions after the first two that you see here may be helpful additions, but are not required. It is important to understand the difference between passive and active suicidal ideation, as this may help you decide next steps in your treatment or care for the patient. On the slide here, you can see examples of active ideation when a patient has specific thoughts about how they would kill themselves or intent, and passive ideation when a patient wishes they were not alive but does not have any plan or intent to harm themselves. Passive suicidal ideation should still be taken seriously and warrants a safety plan, resources, and documentation of next steps that you've taken to keep the patient safe as the provider. Some individuals do have passive suicidal ideation throughout their lives, so it is important to investigate if this is something new, and if not, what has kept the patient from acting on these thoughts. If primary care providers have time in their appointments and feel that they have the rapport built, primary care and other clinical staff, like a nurse or a care manager or case manager, can do a little more investigation on this to ensure that the patient has protective factors in place. I want to reiterate that we know that there can be some anxiety related to asking someone about suicidal thoughts and would like to help you feel more comfortable and prepared to do so. It does get easier with repetition, so practicing with other staff or attending upcoming My Mind office hours to role play and practice vignettes may help. While we are offering some opportunities for office hours in the new year, we want to let you know that if these times do not work for your schedule, you can always reach out to myself or the coordinating center to request a time to meet and discuss any questions you might have related to My Mind trainings. While we want practice clinical champions and liaisons to disseminate My Mind information to other providers at the clinic, it can be helpful for support staff, such as front desk staff or MAs, to attend a training such as Question, Persuade, Refer, or QPR. This training can help non-clinical staff, it's really for civilians in general, to feel more equipped to manage suicidal crisis that occurs in the clinical setting and be able to support the patient and clinical staff. So I included the website here to check out for anyone who is interested. And that's qprinstitute.com. Next, we will go a little more in depth to discuss risk factors and warning signs for suicide, as well as discuss protective factors that help keep patients safe. We suggest screening every patient at every encounter because it may not be as evident to the provider how a physical illness or behavioral health symptoms are affecting the patient on any given day. For this reason, we also suggest that behavioral health does a comprehensive risk assessment. We realize that access to behavioral health can be limited. This is why it is important for primary care to know the risk factors that may cause the patient to be at higher risk, as well as what protective factors can be added and considered to help the patient be safer in interim. Risk factors are situations or problems that can increase the possibility that a patient or a person will attempt suicide. My Mind organizes suicide risk into 4 categories: acute, high, moderate, and low risk. So how are we able to stratify risk in this way? On this slide, you will see the risk factors that are considered acute risk for patients and for suicide. Our co-directors, Dr. Frank and Dr. Amadani, and the behavioral health team at Henry Ford Health have worked to make these buckets as clear as possible and ensure that risk stratification is evidence-based. It is important to recognize that a patient is considered at acute risk for suicide if they present with a suicidal plan or intent, have history of suicide attempt in the last 30 days without any intervening mental health treatment, or if the patient has severe hopelessness, current uncontrolled mania, or current psychosis with command hallucinations and/or severe paranoid delusions. As Dr. Frank would say, these should be very clear warning signs that a patient needs to be hospitalized. If a patient presenting with any of these symptoms is not hospitalized, there should be very good clinical reasons and considerations for safety in place that would justify the decision to not hospitalize the patient that same day. And on this slide, you will see risk factors that are considered high risk for suicide. We know that individuals using substances are more likely to die via overdose, and we also know that impulsivity and lack of inhibition tend to go together with drinking and using drugs. So it is important to keep in mind substance use history and current use. Global insomnia, when a patient is sleeping very little or not at all, is also a predominant risk factor and has been linked to suicidality. As providers, we should always be looking for symptoms of severe depression, anxiety, anhedonia, or when someone can't enjoy things as they usually would, as well as any recent mental health emergency department visits, acute stressors or losses, or a suicide attempt within the last year. Recent mental health emergency department visits and high scores on the PHQ-9, item 9, of more than one, so a 2 or 3 on question number 9, or a high overall score of more than 20 on the PHQ-9 also lets us know that a patient may be at higher risk for suicide. The moderate risk bucket has the most risk factors. Individuals with a family history of suicide, history of drug use disorder within the last 5 years, or opiate abuse in the last year, as well as those with military background or who are LGBTQ+, are among populations that are at heightened risk in comparison with the general population. We also want you to recognize that individuals without any other risk factors may be considered in this moderate risk category due to impulsive behavior, moderate depression or anxiety, current hypomania, an eating disorder, history of chronic pain, or having a traumatic brain injury or inpatient psychiatric hospitalization within the last year. It is important to note that an answer of 1 on item 9 of the PHQ-9 is considered moderate risk as well. I want to add in a reminder here that any patient that has a behavioral health diagnosis has some level of risk, even if low. So in the low risk bucket, we include mild anxiety or depression, bipolar disorder or psychotic disorder in remission, multiple chronic medical problems, and any other mental health or personality disorder. At some practices, leadership has been able to build the stratified risk assessment into the EMR or EPIC. However, I know that you might not have the ability to do this at all, or that it may take time and planning. Therefore, we are providing you with a 2-page or front and back checklist with the different risk buckets that you can read through quickly that will have a protective factor checklist and other important things to consider when assessing risk for suicide. Since behavioral health will mostly be doing this assessment, it is important that they have access to this, but it may also be helpful for primary care physicians to have on hand as well to consider possible risk and protective factors and consider next steps. All right, just a quick little quiz here. So a patient enters your office with a history of being in the military and marks a 1 on question 9 of the PHQ-9 for several days over the last 2 weeks. Without any other information, what risk level would this patient be considered? Low, moderate, high, or acute risk? All right, so if you picked moderate risk, that is correct. Both being a veteran and scoring 1 on item 9 of the PHQ-9 puts somebody at moderate risk without any other risk factors present. So either one of those would cause the person to be at moderate risk. All right, so keep in mind that every suicide risk assessment should include screening and assessment for history and current substance use or abuse, as this might change next steps or referrals for the provider. Again, results of the risk assessment drive clinical intervention. The more we know about the risk, the more we can modify the risk, add protective factors, and prevent suicide to keep the patient safe. Now, as a therapist who has worked in collaboration with primary care, I know that this has been helpful to get messages and warm handoffs at times from primary care, almost like a heads up about possible risk factors when they are referring their patients over to behavioral health. So although behavioral health will be doing the full assessment, input from primary care on risk factors and protective factors can often be key to helping the patient be as safe as possible as soon as possible. Now, I never want to underestimate my audience, so I thought I would give you all a chance to pick out some warning signs for suicide here. So I'm going to play a video from the American Foundation for Suicide Prevention, or AFSP website. And as we're watching the video, notice any warning signs that come up for the father in the video. I do want to let you know that I myself have watched this video multiple times, and even though my job is talking about and working on suicide prevention 5 days a week, at least, I definitely have, had some tears come up at times watching this video. So although I think it is a very impactful video, it is also very real. And I just wanted to give you all that heads up before I press play, that if you are struggling today or have a history of struggling emotionally, or somebody close to you in your life that might be difficult to watch this video, it's okay to take a step away for the next 3 to 4 minutes if you would like to skip it.
Pass the ketchup? Dad, are you okay?
Oh, yeah, just stressed out.
Oh, and the melody is sounding so much better. I can play it for you. Wait, where's your guitar?
I gave it to your cousin.
What? That guitar's like your favorite thing.
I don't need it anymore.
Oh, and I saw Henry today. Says he hasn't seen you around.
Huh.
Maybe you should give him a call.
I will. I will.
No, you won't. You said you go.
Have more fun with your friends.
I want you there.
I'm tired. Some days are just better than others.
I think you should go talk to someone.
It's not that easy.
Dad, I can tell that you're hurting, but we can't keep pretending like everything's fine.
I know. I'm sorry.
Have you been thinking about suicide? You can talk to me, Dad.
It's been a tough couple of months.
Thank you for watching that video and for looking for the warning signs that might have came up during that video. So although it may be obvious that the father in the video was having difficulty thinking clearly and struggling with depression, for all we know, he may have been having any or all of the thoughts and feelings going on the left side of the screen inside, right? Sometimes people voice these things. You may have heard patients in their appointments say they can't think straight or that they're struggling with making decisions. As we hear these things come up in appointments, it can be helpful to do some more questioning to find out how long the person has been feeling this way and how it is affecting the person emotionally. It is also important to consider the warning signs and other risk factors that you see on the right side of the screen. So on the right side, we can see that there was definitely some withdrawing happening. Seemed like he was withdrawing from friends and social activities, losing interest in hobbies and giving away prized possessions, right? Keep in mind these other things on the right side of the screen that are risk factors and protective factors. especially if there has been drastic changes in behavior, such as increasing substance use or having a relapse, changes in appearance, or recent severe losses, just to name a few. Again, keep in mind that the provider, whether the primary care or behavioral health provider, may need to do a little more investigating around the reason why the person feels this way or why these changes are occurring. It is also important to ask how the patient is coping with any of these. According to SAMHSA, protective factors are characteristics associated with a lower likelihood of negative outcomes, or that reduce a risk factor's impact. Protective factors may be seen as positive countering events. Some risk and protective factors are fixed. They don't change over time. Other risk factors and protective factors are considered variable and can change. Behavioral health and primary care providers can help a patient access psychiatric care, and PCPs may even be comfortable with doing a safety plan with a patient or have some designated staff on site to do so. Providers may also support the patient with coping or self-management skills, assisting with means reduction, counseling, and involving family, and just generally building rapport with the patient to help the patient feel supported and comfortable with their treatment plan. Other protective factors, such as family responsibility, spiritual beliefs, and individual meaning of suicide, need to be asked about and discussed further, which is why we suggest that behavioral health providers do a full assessment on the patient's risk and protective factors, as we know that primary care may not have the time or space to do so. Now, looking at these, I just want you to think about, were there any possible protective factors in place for the father in the video that we just watched? So we know that he is a parent. So parenthood or family responsibility could definitely be a protective factor for the dad in the video. All right, now we will shift to discussing lethal means counseling and safety protocols for removal. I want to start by saying that we are not only discussing firearms here, and that it is just as important to keep in mind stashes of medication and other possible lethal means that patients discuss using to try to kill themselves. Now, the statistics are so staggering that firearm safety is impossible not to address, especially here in Michigan, where we have a lot of hunters and military members. Firearms are the most common method of a lethal attempt, with 56% of suicide deaths in Michigan in 2022 being the result of firearms. So if we know that firearms make up 56% of suicide deaths in Michigan, and only 33% of individuals are making it to a behavioral health department before they die by suicide, it is essential for primary care to be considering lethal means counseling and having these conversations with patients as well. I just wanted to start by saying that lethal means are not only things that exist in the home. They can even be found in medical office settings. Therefore, it is important that the room that a patient is in is secure if the patient is at risk for suicide. So both the American Psychological Association, or APA, and the American Medical Association, or AMA, advocate for minimizing anything that can be used as lethal means in the doctor's office and other healthcare settings, and recognize this as a core component of suicide prevention. Office staff should be aware of ligature risks, sharp objects, or medication that can be dangerous for a patient at risk, and try their best to not have access to these in the patient rooms. Every patient should be asked about lethal means availability initially, as anyone could present down the road in crisis or feeling suicidal, right? And this is really valuable information to have when that is the case. The provider should also check in with the patient about this at future appointments. If possible, remove means from the home, and limit access to lethal means, or support that removal. Many things can also be considered as weapons if someone is determined, which is why I want to emphasize the importance of involving family here, as they may be aware of information that you, as the provider, are not aware of. They also have access to the patient and their environment to help ensure safety. It is critical to document steps taken towards lethal means counseling and safety in your office visit notes for yourself and for other providers to be aware of at subsequent appointments. If no handoff is possible, or primary care does not have behavioral health on site, primary care should be addressing access to lethal means with their patients. And there are multiple reasons why this is important. One, of course, for suicide prevention, which is why we're talking about it today, but it also supports child safety and other violence or homicide risks. So there can be multiple benefits to harm and lethal means reduction. First, this will hopefully look like a collaborative discussion in which the provider works with the patient and their support people to identify all weapons in the home and any other possible access to lethal means. It is crucial to take some time here to discuss all possible plans and access to lethal means. When able, it is important to gain the patient's cooperation in the process and receive the contact person's info from the patient and sign a release to speak with that individual. If the patient is in immediate danger, consent and agreement from the patient does go out the window. For example, if a patient states that they have a firearm at home and plan on using it to kill themselves today. The provider may have to reach out to the emergency contact or authorities, even without the patient's consent, to ensure that the patient is not in immediate danger of harming themselves or someone else. Next, establish an individual plan for means removal and safety. If the patient agrees to weapons removal, contact the support person with the patient in the room to implement a plan for weapons removal. Secure agreement of the support person to call back and confirm weapons removal. Instruct the support person to speak directly with the provider. Instead of like support staff or front desk staff, we want them to talk directly to that primary care provider or APP, psychologist or psychiatrist. And do not direct patients or support people to bring any weapons to patient care sites. Just a note here, there is no research to indicate whether it is safe to return firearms to the home after removal. Now, if a patient refuses removal of weapons but agrees to allow communication with a support person, educate the support person regarding the risk of weapons availability and the need to continue to encourage the patient to allow means or weapons removal. It can be helpful here to discuss the treatment plan and solicit feedback about safety with the support person if possible. And if the patient refuses removal of weapons and does not agree to allow communication with a support person, which is possible if they're not in immediate danger, we want to always educate the patient regarding the risk of suicide with weapons availability, ensure that weapon removal is discussed at every encounter, and the conversation is documented, and encourage the use of a gun safe or medication safe. Ideally, we would like a provider to reevaluate risk at each meeting and always document this in the patient's record. Here are some further considerations for firearm safety. 90% of suicide attempts with firearms result in death. This is why it's so important to continually discuss lethal means removal with patients who are at risk. The first fact about the odds of dying by firearm being 3 times higher may be helpful to use with patients if they are considering buying a firearm, which they sometimes tell us, but may not go over as well when you are saying this to a firearm owner. So know your audience with this. Read the room. Keep in mind that males, especially older males and veterans, are at higher risk of dying by firearm-related suicide. On our My Mind Suicide Prevention Hotline handout, you will see that veterans can call 988 or the 1-800-273-TALK number and press 1 to speak with someone if they are struggling with suicidal thoughts or just need to talk to someone as a veteran. It is helpful to have a standard phrase related to lethal means counseling and talk about weapons removal being especially important for people who have children in the home. For example, you may preface with saying something like, "Hey, I know this sounds like a weird question, but this is something we ask everyone. Do you have any firearms in the home or access to firearms? We ask this for your safety and for any others in the home, especially children." You might even let them know that you will be checking in with them on this at future appointments. For people or youth who have a firearm in the home that is not theirs, ask more questions about firearm knowledge, placement, or others who could be in danger in the home. You can get creative regarding bringing in support people to confirm safety or talking to parents or guardians, which we have heard in the trainings that both primary care and behavioral health are already doing. So good job, guys. Prioritize harm reduction always. Practice having the conversation and consider popping in for any upcoming My Mind office hours to practice having that convo um, and get some best practices with discussing this with patients. At the bottom of the slide, you'll see a website for Lock to Live, which is a great tool that patients can use on their own to explore ways to reduce risk or harm with a firearm or other possible means. So it actually takes the patient through um, ways that you could consider reducing harm with firearms, stashes of medication, sharp objects, those different kinds of things, and makes a plan for them to support lethal means safety. Keep in mind that some have stronger attachments to their firearms than others, and that it is important to consider your language and timing when having your conversation with them about harm reduction. And just be sure not to impart your bias on the situation. All right, so feel free to take a break here, pause the video if you would like. Otherwise, I'm going to keep going. So I have another pop quiz here just to see if you are listening. So lethal means counseling is supportive of suicide prevention, other violence or homicide risks, child safety, or all three of these. So which of those does lethal means counseling support? If you said all three of these, suicide prevention, other violence and homicide risks, and child safety, that is correct. Lethal means counseling can support all of those things. Now we will transition over to talking about patient self-management strategies and how to best support patients outside of their appointment. Although everyone's social support system tends to look a little different, we know that involving a family member, significant other, or even someone like a roommate, friend, or loved one in a patient's care has the potential to save lives. We will also discuss how patients can gain support from others outside of the patient's usual social support system. Let's talk about creating a community of healing. We recognize that involving loved ones can feel uncomfortable for some providers, especially if this is not your usual practice. We worry about patient privacy and HIPAA, and sometimes worry that involving family might cause more harm than good. Today, we will debunk that myth. There are many positive reasons for involving the patient's social support system outside of the healthcare system. The truth of the matter is that clinicians are poor predictors of suicide risk. Recent research demonstrates that suicidal ideation alone is not a reliable basis for suicide risk determination. The collateral data or information from family, significant others, or other social support people may aid the clinician in determining severity of risk, as well as chronic suicide risk. Involving the patient's social support system can be therapeutic, and their involvement may lessen claims of malpractice, actually. So when we talk about a patient's social support system, this can mean their immediate family or significant other. It may also include a friend, roommate, or a distant relative, such as an aunt or nephew. This can be anyone that a patient feels is a safe support and that they trust to speak with their provider. Often our strongest support system is the family we choose, so it is important to talk to the patient about who is best to involve in their care and who can be the most supportive to the patient's treatment. Involving social support system may look different for each patient. For example, people who are part of a stigmatized community, including those who are LGBTQ+, may have a lack of support from their biological family, but often have a strong support system of friends that are considered family. Now, when we as providers are considering involving the patient's social support system, keep the following protocol in mind. Support system involvement should be made anytime an individual is acute or high risk for suicide. So social support should be involved for anybody who is high or acute risk. It can also be helpful for those patients who are deemed moderate to low risk and depends on the conversation that the provider has with the patient and the provider's clinical judgment. Collaborate with the patient on who is best to involve in their care and obtain informed consent in the form of a signed release or verbal consent if the patient is on the phone or being seen for a virtual appointment. Of course, always document that written or verbal consent in the chart. And if the patient refuses to include anyone from their social support system, be sure to document this in the chart as well. Always discuss with the patient what you plan to share with their support person. Provide the patient's support person with appropriate information about the patient's treatment, plan of care, and any tools and resources that can be supportive as well. For an adult patient, you can provide the MyMind handout called Understanding and Helping Someone Who is Suicidal to their support person. Or for PEDS patients, you can provide their parent or guardian the handout called Preventing Suicide Tips for Parents. And we do have those handouts in multiple different languages on the MyMind Partner portal. Involving social support outside of the healthcare setting is not a one and done. Really think of the social support system as part of the treatment team and that there will be ongoing discussions related to patient care. We also want to emphasize here that not all patient relationships are healthy ones. Some are not safe or appropriate to include in the patient's care, so it is important to ask thoughtful questions about a patient's safety with these individuals. For example, if there is an individual that the patient feels will use their health information to be malicious, obviously this is not a good person to involve, right? At times, the patient may not even realize that this person may not have their best interest in mind, and we do not find that out until later. If you identify that a support person is unhealthy, it is important to address this with the patient within your session or appointment to explore healthier areas of support or if further referrals or resources are needed. Involving a support person in the patient's care can benefit the patient with further support outside of their treatment team and outside of normal clinic hours. It can also be an advantage to the provider and their care for the patient. The social support person can assist with lethal means removal, monitoring patient symptoms and severity, promote engagement in care, adherence, and healthy activities. They can also help the patient to learn about and better understand their diagnosis. It can be useful for a support person to attend a primary care or behavioral health appointment with the patient. This can help ensure that the social support people are aware of the treatment plan and where they can provide additional support. They might also be able to provide some supplementary information about the patient and their health that the provider might not get otherwise. When people are depressed, they may feel like they are walking around in a fog and having difficulty remembering things. Although we never want to underestimate a patient's ability to manage their own care, having social support in an appointment to obtain and provide key information may be extremely helpful. At times, it is difficult for patients who are depressed to get out of bed and complete hygiene and other daily activities. So it's understandable that they may be struggling to get to their appointments, take their medication, or just be present during those times. Involving support people can be a real game changer in these situations. If the patient feels suicidal, their support person can also support the patient with calling 988, calling 911, and/or taking them to the nearest ER. Family, friends, or loved ones can update the treatment team if the patient goes into inpatient or IPD, and this can be very helpful because as providers, we're not always aware of this, especially if the patient goes into another hospital system's ER or gets admitted. Most of you have probably had experience working with patients that have lack of social support. Now, there can be many reasons for this and why this is the case, but for myself as a therapist, it is an indication that the patient may need added support or resources. It is especially important that patients who do not have supportive family, friends, or loved ones feel supported by the treatment team and that the treatment team works together to support the patient. In my mind, we talk about the two-prong approach with primary care and behavioral health partnering to support patients. But for patients at risk for suicide, coordinating with other specialty providers may be helpful. So these can be providers in other departments such as pain management, endocrinology, oncology, and maybe a patient who benefits from working with case management with any of those clinics too. Providers can encourage participation in local or virtual support groups and community organizations. Even something like volunteering can be a positive social experience for a patient that can help them feel like they are part of their community. On the next few slides, we provide some resources for further social support. Some of these serve as adjuncts to treatment, with research to suggest they improve patient care and outcomes. Referrals to crisis and suicide prevention hotlines and support groups can also play an active role in supporting patient self-management. Individuals can call the Suicide and Crisis Lifeline by dialing 988 or the good old 1-800-273-TALK. And people can also text 988 to receive support or chat online. This line provides free and confidential emotional support to people in suicidal crisis or emotional distress 24 hours a day, 7 days a week across the US. Again, 988 is for anyone experiencing behavioral health related distress. So this can be thoughts of suicide, mental health or substance use crisis, or just needing somebody to talk to because they're in emotional distress. It is a national network of over 160 local crisis centers, combining custom local care and resources with national standards and best practices. People can also dial 988 if they are worried about a loved one who may need crisis support. And you can call this number and get support in multiple languages. So it'll actually prompt you to press 2 if you would like to speak to someone Spanish speaking. However, there are interpreters that speak multiple languages on that line as well. And although 988 does support people who are LGBTQ+, the Trans Lifeline is another free hotline for transgender people experiencing a crisis. This includes people who may be struggling with their gender identity and that are not sure if they are transgender. So you can let the person know that even if they are not sure, they should still call, even if they're not sure, just to get some support. And the Veterans Crisis Line connects veterans in crisis and their families and friends with qualified, caring Department of Veterans Affairs responders through a confidential toll-free hotline, online chat, or text. Veterans and their loved ones can call 988 and press 1, chat online, or send a text to 838-255. So that 838-255 is specific to veterans. They can also text 988 and let them know that they are a veteran. And you could probably get to the same place, but that 838-255 is specific for our vets to receive confidential support 24 hours a day, 7 days a week, 365 days a year. And just a note here, there is also support for people who are deaf and hard of hearing on that line. Linking patients to community resources is crucial to a successful management of acute and chronic behavioral health symptoms and effective mental health care. The National Alliance on Mental Illness, or NAMI, is a great resource for individuals that are impacted by mental health. NAMI does provide support and resources on the national, state, and local level, including local virtual and in-person support groups that individuals can attend. The websites are included here, and we do have a handout on support groups on the MyMind Partner portal through NAMI. We wanted to provide some other support group options for providers to refer to as well, and to utilize themselves if feeling that they need further support. The Depression and Bipolar Support Alliance has some good educational information, resources, and online support groups for individuals who are managing these diagnoses, as well as their support people. And the Anxiety and Depression Association of America website states that they are triumphing through science, treatment, and education, and offer educational information even in webinar form, as well as some peer-to-peer groups. We did include websites and information on AA, Alcoholics Anonymous, NA, Narcotics Anonymous, MARA, Medication Assisted Recovery Anonymous, as well as Codependence Anonymous and Smart Recovery. So AA and NA are specific for individuals who are trying to stop using alcohol or other substances. Similar to Smart Recovery, but that is a group that is specifically non-religious. So there is some religious aspects to AA, NA, and Codependence Anonymous, whereas Smart Recovery is specifically for someone who does not want that religious context in their groups. These groups are free to attend and are included on the handout in the MyMind Partner portal that has more general support groups on it. We also included Henry Ford's CARE program, which has a lot of good resources for caregivers and is open to individuals even if they are not receiving their care at Henry Ford Health. If providers or case managers have time in their appointments, they can discuss possible support group referrals and even look at types of groups and locations with the patient. It's also important to address barriers or challenges to the patient utilizing community support. And here I just wanted to highlight some of the organizations and websites that support individuals who are survivors of suicide, including Alliance of Hope and Kevin Song. They provide support to survivors of suicide attempt, as well as loved ones who are affected by a suicide. The Compassionate Friends specifically provides support to families after a child passes. And New Hope Grief Support Community has a variety of ongoing loss-specific grief support groups that are no cost or pre-registration required to attend these grief support groups. And all of these can also be found on the support group handout in the MyMind Partner portal. We continue our training today discussing further patient self-management strategies. Giving patients a central role in determining their care can help foster a sense of responsibility for their own health. Patients need information to become effective managers of their own health, and they must learn to take better care of themselves to keep those chronic illnesses under control. And this extends beyond physical health, as we know that patients' physical health often suffers along with mental health and vice versa. Next, we will talk about some strategies that can support patient self-management. The hope is that you will be able to walk away with at least a few different ideas and resources of ways that you can empower patients that you work with to manage stressors and symptoms related to mental health. Keep in mind that healthy self-management can include working with the patient to identify coping skills and healthy activities, similar to like what you see on the screen here. So painting, gardening, meditation, things like that. Using a collaborative approach, the healthcare provider and patients work together to define problems, set priorities, establish goals, and create treatment plans, while often solving problems along the way. This does not mean waiting for a patient to ask for help, as we are all aware of the stigma related to mental health. In order to meet this need, it is essential for patients to have information about suicide prevention, information regarding their behavioral health diagnosis, a variety of self-management tools in a variety of formats, including the 988 hotline, safety plan, maybe a list of books or websites or self-help groups that could be helpful. They should also have an introduction to the cognitive problem-solving approach. So patients will be getting cognitive behavioral treatment and strategies in behavioral health. However, primary care can model this by working with the patient to challenge some automatic negative thoughts related to their mental health or behavioral health diagnosis. If you want to learn more about some of these tools, we do have handouts on the My Mind Partner portal with information on problem solving that primary care could even work with patients on or give them to do outside of their appointments. We also have some dialectical behavioral therapy handouts for our behavioral health participants in My Mind. While you may not be using these as primary care providers, they are available for you to check out. My Mind recommends starting the discussion of self-management strategies at the patient's first appointment by talking about healthy activities that the patient has engaged in the past or is doing currently. As providers and patients, we often underestimate that patients already have answers as to what helps them feel better. However, they might be lacking motivation or dealing with barriers that may be environmental or social in context. We included a handout with self-help books on the My Mind Partner portal for you to check out and share with your patients. We are looking to add more to that list down the road. One book that I would suggest for primary care is Motivational Interviewing in Healthcare, Helping Patients Change Behavior. So you can find that on the list, written by Stephen Rolnick, William Miller, and Christopher Butler, and is a good book that primary care providers can use to start working on some motivational interviewing techniques that they can use with patients who are at risk. Here, I just wanted to quickly talk about a resource that providers can suggest for patients to use when they are struggling emotionally, possibly even feeling hopeless or suicidal. A hope box is a simple but powerful way to help someone remember their reasons for living during moments when all hope seems gone. So there is actually a handout on the Your Life, Your Voice website, and that's up at the top of the screen on this slide here that walks you through creating a hope box that you could also share with your patients. Really just helping them to pick things out that mean a lot to them and give them hope, to put in a box or an envelope and keep somewhere near that's easy to access for them to look through mindfully when they need some support or they're feeling down or out of hope or suicidal. So a nice extra thing that you can suggest patients to do, and there's some information about that on that website. All right, so moving on to safety planning. A safety plan is a written set of instructions that a patient and clinician create as a contingency plan should the patient have thoughts of harming or killing themselves. Safety plans are usually created in behavioral health, but important for primary care to be aware of and able to ask if the patient has a safety plan already in place. While a full safety plan includes all the elements listed here on the screen, the top most important things for primary care and behavioral health to keep in mind are that the patient has that 988 helpline and knows that they can text or call that number. The patient's emergency contact and support person is up to date in the EMR. This chosen person is trusted to ensure patient safety. Therefore, they should be close in proximity to the patient. And if there's no support person available, which sometimes happens, encourage the person to find a positive distraction, maybe some cheerful music or watching a cartoon that makes them feel happy, and go to a place where the patient is not alone. You can call the police to do a wellness check on a worst case scenario, of course. Um, this is a last resort as it can make the patient feel anxious or not want to return. So having a safety plan is a nice thing that they can use in interim, and you can discuss them using in between appointments. We always want providers to support with removal of lethal means, and primary care should encourage the patient to go to the emergency department if the patient is in danger or is planning to do something to hurt or kill themselves between appointments. Per the research, we know that safety plans reduce suicide risk by 20 to 25%. In a recent article, co-authored by Angerhofer and the MyMind co-directors, this was found to be true when paired with suicide risk screening using the PHQ-9 item number 9 to identify risk. According to research gathered by Rainbow et al. 2024, suicide-related coping is a specific set of skills describing the knowledge and confidence to use self-guided and external support systems to manage and control suicidal urges. These skills may directly reduce future suicide risk, as suicidal ideation, depression, and hopelessness appear to be lower in those with stronger suicide-related coping skills. Use of internal coping skills, such as self-guided cognitive redirection, has been shown to reduce suicidal ideation in real time. And stronger external coping, like seeking support from others, has been associated with lower levels of two major interpersonal drivers of suicidal ideation, which are thwarted belongingness and perceived burdenness. So we know about those from Thomas Joyner, and we know that these safety plans can help to offset those feelings and helps to support greater controllability of suicidal urges. So this safety plan template is available via the MyMind Partner portal and our website. And again, patients can complete a safety plan on their own via the Suicide Safety Plan app. Over the next few slides, I would like you all to complete a safety plan for yourself today. If you have never done this with a patient, this can be a good opportunity to see what this is like. So go ahead and take out a piece of paper and a pen or pencil, or just open up a Word document or your notes on your phone so you can write your answers in for your safety plan. As a note here, it is ideal for the provider to complete the safety plan and then provide that to the patient, as it is important for the provider to be aware of the answers and ensure that the safety plan is being filled out. So I want you to start by putting yourself in your patient's shoes. Imagine that you are a patient that is very depressed or emotionally struggling. You may have difficulty completing this. For some patients, it may be difficult for them to even brush their teeth, let alone want to go for a walk. Having verbiage to normalize this experience and support the patient in doing the best they can is very important here. So I'll walk through the first couple steps as you fill out your own answers. I would usually start the conversation out with saying something like, I know you had mentioned having thoughts of not wanting to be here, and I think it would be helpful for us to do a safety plan today. If the patient denies a need for this, I would usually counteract that with letting the patient know that this is normal practice and that completing a safety plan can be helpful and therapeutic, even when someone is not in danger of hurting or killing themselves, and can be used just to think through things that help them feel better. I also let them know that I can help them along the way and that it shouldn't take long, about 10 minutes or so. So step one is recognizing your warning signs of a crisis developing. If the patient is having difficulty finding an answer, I might say something like, when you have felt extremely anxious in the past, what thoughts or feelings or behaviors did you notice in yourself? So you can switch out anxious for sad, angry, suicidal. But when you've had this feeling in the past, what thoughts, feelings, or behaviors did you notice in yourself? You can also say some examples are, and then read the examples on the form. That's why they're there for you. So go ahead and write those answers down for yourself now. What would your warning signs be for a crisis developing? If you are familiar with the patient and are aware of any of their warning signs, you can make a suggestion and say something like, I know in the past you said that you feel like your temperature goes up when you're feeling angry. Do you want to add that here? So I'll give you a minute to put in those warning signs here. Step two is naming things that you can do to help yourself feel better or that can be self-soothing. Can you name a few things that help you feel better or give you comfort? Again, normalizing that this might be difficult for the patient is important. You can't tell the patient to get out of a dark hole if they can't open their eyes, right? So you must validate the patient for trying and doing the best that they can. If the patient is really struggling with this, you can read off the examples or even give them some ideas for self-management, possibly by providing one of the My Mind handouts or some resources. Keep in mind that the answers here should be healthy and should not include drinking alcohol, using drugs, or other activities that patients have difficulty managing, like gambling, for example. So it's really common for patients to say, oh, I would like to have a glass of wine. That's something that is soothing or gives me comfort. So I will usually suggest finding something else if we can. So hopefully you wrote down your answers for the first two steps. Feel free to pause if you need to. For the third step, I want you to think about and write down your three most important reasons for living. I know this is a big question, so do the best you can. Now, it is important to recognize if the patient is struggling with completing step three, and this can be a warning sign or indicator to the provider that the patient may need further support. If the patient cannot think of any reasons for living, you can ask them, what helps them to keep going or what motivates them to attend their appointments, go to school, go to work, those kinds of things. It also can be a small thing and may not be what you or I would think of. So hopefully you have those steps, those things down for step three. And for step four, consider positive things that you can focus on in the moment when you are feeling overwhelmed, depressed, or having suicidal thoughts. For this one, I often name off the examples that are provided and usually say, these can be anything like a nice memory, something positive that happened to you, something good in your life, or people who care about you. Just do the best you can. So go ahead and write those down for yourself now. What are some positive things that you can focus on in the moment? It may be helpful to give those examples one by one, as this is probably the toughest question of them all and can be overwhelming for patients. If the patient is having difficulty thinking of anything for step 4, for example, maybe they feel like they have named everything off already in the last questions. One, you can let them know that they're allowed to do repeats. There's no safety plan police. But also consider using a technique that you're aware of that you can help the patient with. So maybe using guided imagery and asking the patient to think of a relaxing place that they can picture, like a beach or a field of flowers, and suggesting that they think about all the things that they could see, hear, smell, and feel when they are in that place, and then writing that exercise down for step 4. Again, just being creative. Maybe it's thinking about a thank you that they received from someone or someone acknowledging their hard work. Completing a safety plan with a patient can also be the time that you let them know that you have been listening, and you can possibly make some suggestions on these things if you know the patient and have the rapport built. In turn, safety planning can also help a provider build rapport and increase medical trust. In step 5, I want you to think of your top 3 people that you would call if these strategies do not work or if you are in danger of hurting or killing yourself. So who would your number 1 go-to person be? Who would the second person be, and who would the third person be? So go ahead and think about this and write their names down now and their numbers as well. I always suggest that the patient looks up the number if they don't know it off the top of their head, so that they have it on the safety plan and the provider has it as well. Again, like step 3, it is important for the provider to recognize if the patient is struggling with identifying others in their life that they can reach out to for support. This is another indication that this patient might need further support and resources, possibly referrals. It is important that the patient chooses safe, supportive people here for obvious reasons, but also because we want um, the patient to pick people that they will actually reach out to when they are in crisis. Although the patient may pick individuals that you may not consider, I may not consider, such as a roommate or a coworker, it is important that they feel comfortable and safe reaching out to these individuals and that they are supportive to the patient. So hopefully you have your 3 people written down there and their numbers. And then for step 6, this is to be completed with a therapist and psychiatrist contact numbers, as well as the suicide prevention hotline and text line. So if you don't, if the patient isn't set up with like the therapist or psychiatrist yet, you can keep those open for when they are, but you can also put some notes on the side with like a 24-hour clinic number or primary care number or case management number as well. Step 7 should say something similar to what you see on the screen here, stating that if the above steps are not helpful and I feel I may take my life, I should go to the nearest emergency room or call 911. So now you've gotten the chance to see what a safety plan looks like and how to fill one out if you haven't already. As the primary care physician, it may be helpful to work with your behavioral health partners to know where to find this information in the patient's charting notes, or coordinate with behavioral health leadership to be alerted of safety plans when they are completed with behavioral health and vice versa. So just keeping that line of communication back and forth between primary care and behavioral health strong. And if staff at your practice are able to support this intervention at your clinic, some important things to keep in mind as you're supporting patients with safety planning is that the provider should talk to the patient about what to do with the plan. Providers can make multiple copies for the patient to keep in different places, like in their wallet or purse or at their bedside. It's important to talk about when to use the safety plan. Maybe it's if they're feeling hopeless or suicidal, talking about checking on that safety plan and seeing what they can do to help themselves feel better, and reminding the patients to follow the steps. It might be helpful for a significant other or a close loved one to have a copy and understand its purpose. And it's also vital for a behavioral health provider to follow up with the patient as to whether the patient is using it and if it is helpful or if it needs to be updated at future appointments. All right, and now you have a safety plan, hopefully, that you can review if you need it in the future. And thanks for filling that out and playing along. From the research, we are aware that sending caring cards after an appointment is an effective strategy for reducing suicide. And this has been replicated in multiple well-controlled studies. This can be a low-cost strategy, especially if sending messages digitally via the electronic medical record or EMR. This may also include a letter via snail mail or a call after an appointment or discharge. My mind suggests using caring follow-ups and outpatient ambulatory care at the time of the first missed appointment. Anytime a patient is at high or acute risk, or anyone that you feel would benefit from a follow-up. We always say, when in doubt, reach out. And this is why we have a caring card letter template and a postcard template that is simply just a general reach out to let them know that you care and providing them with the 988 text line and call line. So we have those different versions available on the MyMindPartner portal. We also suggest providers in inpatient or residential units send a caring letter on the day of discharge, and that template is available as well. So here you'll see an example of a caring card that is available on the MyMindPartner portal. We also have letters specific for those other 4 scenarios that I just mentioned. So feel free to copy and paste the information to print on your practice or system letterhead. And if you need Word document versions, feel free and let us know. We know that's a little bit easier when you're sending snail mail. And notice here that the verbiage in the letter validates the patient's situation and emotions and lets the patient know that you are reaching out because you care and are concerned as their provider. It should include the clinic number as well as an after-hours number if available, and should also always include the suicide prevention hotline and text line number. All right, so at this point, you have screened the patient at your primary care office and have asked the patient if they have any plan or intent to kill themselves, and possibly discuss some risk factors and protective factors as well. You also have information on some of the brief interventions that can be helpful for reducing the likelihood of suicide attempt. So what next? Let's talk about triaging patients who are in crisis. All right, so for this first scenario, you are on the phone with a patient that has active suicidal ideation with plan or intent. For primary care providers, if you have a behavioral health partner that you can call or that is on site for collaboration, you could contact them for assistance with this process. On the flip side, if you do not have behavioral health staff in the clinic or immediately available, you may have to handle this on your own. So what steps would you take here for a patient who is actively suicidal and on the phone? So I'll give you 30, 60 seconds here to think about this before we give you some suggestions. All right, so most importantly, confirm the patient's full name, contact number, and address where the patient is located in case you are disconnected. Ask if there are family members or support people there with them and get them involved for further support. Ask the patient if there are any weapons or other means of harm in the home. Inform the patient and their support person that you will call 911 and send help to their location. And do this after confirming their location, of course. Now, you or designated staff should maintain contact with the patient until police or EMS arrive. So you may need to stay on the phone and involve other staff to call 911 or vice versa. When speaking with the police, note the officer's badge name, badge identification number, if you can, and the time that you spoke with them so that you can document this in the EMR, just in case you need it for future information or for others that might need it. So most importantly, trying to get the patient to the right place, to the ER for further evaluation, and making sure to do that as streamlined and safely as possible. Now, having a patient with suicidal plan and intent in person may be easier to manage if you have support staff nearby that can assist. However, this can feel very rushed and stressful when staff are trying to maintain the clinic flow while a patient is in crisis. So first and foremost, stay calm and breathe. Thank goodness that that patient got to their appointment today and they are living and breathing in front of you. Now consider, what other things should you keep in mind when you have a patient who is suicidal in the clinic setting? So how would this situation, a patient with active suicidal ideation in the clinic setting, be any different? So I want you to think about that, and I will put some suggestions up on the screen in just a second. All right, so just a little bit different than having someone on the phone. We want to make sure to place the patient in a secure and supportive environment and do not leave the patient alone. So just like we're asking a patient on the phone if their environment is secure, asking about lethal means and staying on the phone with them. Similarly, in the clinic, we want to not leave the patient and make sure that the room is safe. We can ask if there are any family members or support people there with them. Sometimes they're in the car or in the waiting room. Again, remove any immediate means of self-harm, especially those in the room, but we can ask the patient if they have anything on them as well. Discuss the plan with the patient. So dispositions may include calling 911 to send the patient to the emergency department for further evaluation, or when possible, if behavioral health is on site, you may have the ability to directly admit the patient to an inpatient department. Other dispositions would depend on additional risk assessment. So if behavioral health determines a less restrictive level of care is indicated, maybe partial hospitalization or intensive outpatient program might be considered. And if the patient has a plan but no intent, this may be a patient that is a little better suited for IOP or PHP, depending on their protective factors, which would be best assessed by behavioral health. Never forcibly restrain a patient or physically prevent a patient who is refusing evaluation. If they do leave AMA, just call security or 911 and report that the patient left AMA, and you may need to request to do a home safety check. If the patient attempts to leave AMA, be persistent in trying to get them to stay. And if they do leave and you can get any information like a license plate, make and model of car, especially if they are at immediate danger, that can be helpful for authorities. And in this situation, primary care would either be getting an emergency consult from their behavioral health partners or sending the patient directly to the ER. MDs or DOs may be doing a certification. Otherwise, other folks would be filling out a petition. This last scenario is a patient with passive suicidal ideation, but still at risk. This can feel like a little bit more of a gray area for providers, especially primary care providers, who may worry they do not have the time or environment to talk through these feelings with the patient. The important thing here is for the provider to do the best that they can to keep the patient safe and avoid hospitalization if possible. So for these patients, we want to refer to psychotherapy and/or psychiatry, or contact your designated behavioral health partner for coordination of care if possible. The collaborative care model can be a good one for a patient in this situation and can vary depending on the structure of your organization. Always confirm the patient's home address and patient phone number and emergency contact. Identify supports and patient's plans for upcoming days. Are they future oriented is good to figure out. And if they have support people that can be involved, if the patient is agreeable. Complete a safety plan with the patient or recommend them completing one on the Suicide Safety Plan app. Remember, current research indicates that safety contracts do not have validity. So having the patient sign something saying they won't kill themselves before their next appointment is something that we know from the research is not supportive of suicide prevention, but we do know that safety plans are. So that safety plan is crucial for a patient in this situation. Always provide the patient with any other self-management tools that can be helpful. The hotline and text line number 988 are listed here on the slide as a reminder. Persuade the patient to get help if symptoms worsen, and strongly encourage the patient to reach out for help and to not hurt or kill themselves before their next appointment with primary care or behavioral health. So not so much getting a safety contract, but just getting that agreement that they are safe leaving today. If the patient's on the phone, schedule the patient for an in-office or video visit with primary care as soon as possible. Again, it's important to consider if the patient is future-oriented and does the patient have people outside of the provider for support. Discuss with the patient if it is necessary to contact the patient's social support team to update them. It is nice to have a robust set of self-management tools and ideas for the patient to use. So again, any of the things that we just discussed during the last section could be helpful for this patient. On this side, you'll see our recommendations for psychiatric referrals and timeframes. You'll see that hospitalization is recommended for patients who are at acute risk. Patients at high risk should have a psychiatric evaluation within 48 hours and within 7 days for moderate risk. We suggest using your clinical judgment regarding making a referral for patients at low risk and discussing with the patient their psychiatric needs. We also have recommendations for psychotherapy, so patients who are acute risk should also be receiving a psychotherapy referral post-hospital discharge, and hopefully seeing that psychotherapist within 72 hours of discharge. For a high-risk patient, we would want them to get in with a therapist within 5 days, and within 7 days for moderate risk. Again, up to your clinical judgment for that low-risk patient and depends on your conversation with them. It's important for primary care to know care pathway recommendations and be able to do some intervention with the patient, which is why we briefly discuss lethal means counseling and other patient self-management strategies today, and hope that primary care and behavioral health can partner to support their mutual patients with all of these things. So we talked about some recommendations for scenarios with patients with active and passive suicidal ideation and started to actually talk about the care pathway already for suicide prevention. Now we'll shortly, briefly discuss what a care pathway is and how you can start to formulate a care pathway for suicide prevention or strengthen the suicide prevention care pathway at your site. Our co-director, Dr. Amadani, states that a care pathway is the journey that a patient takes when accessing the healthcare system. A suicide prevention care pathway is an intervention and visualization of a patient's journey in the healthcare system that begins with the patient being screened for suicide risk in primary care and behavioral health settings and provides recommendations for next steps for the patient and providers involved. So the suicide prevention care pathway promotes suicide risk screening at every patient encounter and provides recommendations to promote safety throughout the experience with the goal of reducing suicide. It supports the care team with guidance on best practices and next steps related to the patient's suicide risk screening. It facilitates communication among team members and collaboration with family or social support people outside of the healthcare team. Defines roles of the multidisciplinary team, and also helps to identify resources that support safety, much like those that we just discussed, like crisis lines and self-management tools. Now, our initiative is currently focused on outpatient behavioral health and primary care patients. And our zero suicide care pathway is based on population-based depression screening with the PHQ-9 using that item 9 to screen for suicide risk. Now, we know that patients may be seen in emergency departments, urgent cares, and may also receive care through partial hospitalization programs, intensive outpatient programs, or substance use programs. So as we continue to grow as a collaborative, we recognize these things and are considering these for possible expansion as we are working with more and more providers across the state of Michigan. And as we think beyond the ambulatory care setting. So essentially, your clinic's suicide prevention care pathway is your specific suicide prevention practices and protocols mapped out in a way that is 1, easy to view, use, and reference for all staff. 2, tailored to your clinic and patient population and utilizes evidence-based approaches. And 3, your care pathway will include transitions in care and consider patient safety during these transitions, including access to protective factors. Now, we know that you may just be starting to formulate your clinic's suicide prevention protocols and processes, or maybe in the process of getting them solidified to share with your team. As you make strides to increase knowledge and understanding regarding suicide prevention practices in your clinics, we want you to keep in mind the following questions that you see here on the screen. Even if you already have a protocol and care pathway in place, it is good to check in with others on your team to make sure that they are aware of the protocols and that everyone is on the same page. It's also good to find out what is working and what's not working regarding any of these processes and see if they need to be tightened up or focused on for improvement. For example, identifying missed opportunities for screening and making adjustments that ensure that more patients are being screened. Here you will see our example of a suicide prevention care pathway for primary care. It is important for both primary care and behavioral health to be aware of the zero suicide guideline recommendations to be able to fully support their mutual patients. As a note, I'm aware that this is very small on the screen and the writing is small here in the flow chart. So we do recommend checking out the suicide prevention care pathway for primary care on the MyMindPartner portal. And on there, you can zoom in a little bit closer and be able to see and understand it a little bit better. So in this care pathway, primary care patients enter the zero suicide care pathway at the point of population-based depression screening using that PHQ-9, item number 9. So we'll walk through the care pathway together here. In this scenario, the patient enters the care pathway at the top left corner in the primary care office and is screened for suicide risk. If the patient scores a 0 on the number 9 of the PHQ-9 and there's no other risk factors or behavioral health reasons, that score is documented and that patient returns for their next appointment and is screened again. If the patient screens 1, 2, or 3 on item 9 of the PHQ-9, primary care screens for immediate danger, asking about plan and intent. And if the patient says they do have plan and intent to kill themselves or has any of the other acute risk factors, which we do have in this box here for a quick glance, there's a good chance that that provider will be sending that patient to the emergency department for a psychiatric evaluation that day. That evaluation will be done in inpatient and we do, or in the ER, and we do ask that the provider, primary care provider, has an appointment schedule within 7 days with the patient. If the patient denies plan or intent, we still suggest counseling on lethal means and providing 988 and other self-management resources. If the primary care provider feels comfortable, they can complete a safety plan with the patient or ask designated staff to do this, especially if they have any behavioral health folks on staff. If the patient scores a 2 or 3 on item 9 of the PHQ-9, they are considered at high risk for suicide. If the patient does not have any acute risk factors in primary care and the patient feel that the patient can wait for a psychiatric evaluation from behavioral health, the recommendation is for the patient to be seen within 48 hours or within the next 2 to 3 days after the appointment. Now, if a patient scores 1 on number 9 and does not have any risk factors that would cause them to be at higher risk, they would be considered moderate risk, and it's recommended that they are evaluated by behavioral health within 7 days. Once the patient reaches behavioral health practitioners will complete that screening again and do the suicide risk, the full suicide risk assessment, as well as asking about plan and intent and all of those things, doing lethal means counseling and assessment, and making sure that the patient is safe. We also have a behavioral health primary care, we also have a behavioral health care pathway for suicide prevention that you see here. Behavioral health and primary care should include consideration for each other's roles in suicide prevention in these care pathways and can even flow from one into the other or create an integrated suicide prevention care pathway if that works best. So although we have these suggestions for suicide prevention care pathways, we know that every clinic is different, every PO is different, the area is different, staffing and population is different. So we always want you to create what works best for you, and we are here to help provide some quality improvement with that. So here we have our key takeaways for our training today. Screening for suicide risk, providing lethal means counseling, and involving a support person can promote suicide prevention and can benefit both the patient and the provider, possibly even the support person involved. Providing self-management resources are key to the patient being able to maintain mental health and sustain management of suicidal ideation. Collaborative safety plans give the patient something to reference outside of normal clinic hours. Safety plans should always include the suicide prevention hotline and text line number and should be reviewed at upcoming sessions. And keep in mind that caring cards are simple and helpful tools that providers can send after an appointment and should include multiple options to access care. All of these aspects, including supporting patient safety during transitions in care and working with other providers on the patient's treatment team, really culminate to form a strong suicide prevention care pathway. MyMind hopes to support your clinic in its journey to strengthen the suicide prevention care pathway by providing tools such as education on the Plan, Do, Study, Act, or PDSA process, which you will receive in Module 3. If you haven't signed up for Module 3, please do so and work on getting more familiar with your current suicide prevention care pathway or protocols and procedures related to suicide prevention in your clinic, as we are waiting for that Module 3 and as you're thinking about the upcoming PDSA project. We always provide some references if you want to look up any of the information. You can reach out to myself directly or to the My Mind Coordinating Center at the email here. We are always interested in feedback and trying to improve ourselves, so feel free to provide us some feedback for that as well. And we also have a QR code here for 988 call and text line. We want you to be able to share that with patients, of course, but we also want you all to use that yourself if you need it. We know that you are a human being at the core and you may also struggle. So please let PO leadership, let My Mind staff know if you are struggling in any ways that we can support you, and use that 988 number if you need it. Always take care of yourself. Always put your oxygen mask on first before you help the next person. Thank you for checking out this training today. We want to support you as you support patients daily in their healthcare journey and try to help them to be as safe as possible and healthy as possible. You guys are all amazing. Thank you for doing what you do. And please let us know if you have any questions or need further support. Thank you and have a great day.